Thank you very much. I'm currently at the Banner MD Anderson Cancer Center, but I'm looking very much forward to some of the other talks as my background Ph.D. is in molecular virology, neuroimmunology, and medical genetics. So I'm very excited about that. I currently lead the subfield in neuro-oncology with respect to the neuro-oncology of women, dealing with not just pregnancy and brain tumors, but also the exposure to cross-sex hormones or other exogenous hormones and how that might influence our outcomes in tumor treatment. I'm going to be talking today about how we can improve our understanding of leptomeningeal disease presentation and the complications related, as well as some innovative treatment and surveillance approaches before going into a brief explanation of some of the pathophysiology and diagnosis of LMC based on our broad audience. So starting with case 4 here, really dealing with a 44-year-old woman who dealt with many months of back pain that was forwarded to chiropractors, given opioids or steroids, and the patient ultimately found that she had a mass in her breast. This is the way that most of my patients identify that they have a breast cancer, despite the fact that the COG does not necessarily recommend or encourage physicians to do self-breast exams or people to do those at home. So this young lady had a stage 4 triple negative breast cancer. PET scan shows diffuse metastatic disease, probably explaining some of her back pain at that time, but that evaluation was not done. They did understand that the patient, being under age 60, didn't have the BRCA gene mutation. They put the patient through with therapy and palliative spinal radiation. And the first evaluation of her brain after therapy was demonstrated as normal. Of course, this is after therapy. As well, she has a very nice looking PET scan with a CT objective response. Unfortunately, by May, there was numbness, tingling, and twitching again. They thought it was just a neuropathy and put the patient on Neurontin. 6 days later, she was in the ER and status epilepticus. This is what her brain looked like with multiple metastatic disease. And we can see here very clear leptomeningeal enhancement. We standardized a process at my initial institution. I brought that over now to MD Anderson and Banner, where we do whole brain radiation therapy, placement of the myoport, and then intrathecal chemotherapy targeted to treat the areas, to treat the molecular basis of the tumor. Here we have a picture with the 3D rendition of the leptomeningeal disease. So all of these pieces here, the pink, represent the leptomeningeal disease. Within 2 months of intrathecal therapy, we were left with 2 focal points of disease, which we hit with targeted radiation therapy. This patient was able to experience within 9 months of being on therapy, within 2 months, she was cleared of the malignant cells, but over the next 9 months of being treated, improved brain imaging. Of course, her ambulation improved, controlled the seizures and pain as well for this patient. Medical oncology, however, determined her ineligible for clinical trials based on her history of having leptomeningeal disease. This was a complication for her because she was never able to get any of the advanced therapies or go on to any of the clinical trials. She later succumbed to tumor microemboli syndrome. So the take home from this first case is understanding the health literacy gaps and really the guidelines that would prevent a woman or anybody from knowing whether or not they have breast cancer based on the discouraging of patients to do self-breast exams. The delay in detecting the breast cancer by either the patient and her caring physicians, and the delay in consulting the neuro-oncology team to evaluate what was thought to be a neuropathy. Ultimately, she was excluded from clinical trials, and this is what limited her survival. In case 2, there was a 58-year-old male business owner presented with altered mental status to the emergency room. He noted in his evaluation, or someone that was a representative noted that he had traveled to Mexico in the past month and had a history of prostate cancer. Unfortunately, the differential based on the mention of being in Mexico was neurocystic sarcosis or some other neuroinfectious disease, metastatic disease of an unknown primary, and then based on the rarity of prostate cancer going to the brain, the patient was really not thought to have this high on the differential. We all know that neuroendocrine prostate cancer or small cell cancers will make their way to the brain, and also that visiting Mexico in the past month does not make a neurocysticercosis a high-risk patient. So the patient presented to the ED with this image done and completed in the emergency room. Unfortunately, he was sent home from the emergency room and told to follow up. Somehow things were lost in translation. And a month later, he comes back with this picture of his brain. Because of the fact that neurocysticercosis was still high on the list of things and neuro-oncology had not yet been consulted, the patient moved on to biopsy of the lesion, found out to have neuroendocrine prostate cancer, and his disease in the body was negative. So they recommended hospice. They consulted our team, and we advocated for the patient to initiate treatment. After the initiation of treatment with the Ommaya port in place and whole brain radiation, someone started to talk again about hospice, worried that the treatment was futile and that it was burdensome to give this intrathecal chemotherapy. More patient advocacy and treatment continuation led to this picture of his brain. And so you can see that's just 1 month, basically, and a half from the initiation of treatment. So from the start of therapy, he had no evidence of disease. And so he had a very nice treatment response. And at some point, because he had no evidence of disease in the body, his primary medical oncologist decided to discontinue decided not to start any systemic therapy. I would argue that if you have prostate cells in your brain, they're coming from somewhere. And so the idea of treating systemically with the chemotherapy agent to stop the influx of these cells into the brain that have found a very nice pathway to the brain, we need to treat with systemic therapy. After this progression of the disease showed up in the brain, still no evidence in the body, I was able to convince the medical oncologist to put the patient back on systemic therapy that crossed the blood-brain barrier and continued intrathecal therapy. And we got this beautiful response here. So from the start of disease to treatment, we're able to see a very nice and durable response to therapy. Ultimately, the medical oncologist discontinued the systemic therapy. The patient, my work becomes quite futile at the level of the brain, trying to protect the brain when there's a constant spigot turned on for these cells to make it into the brain. The patient subsequently died from his disease. And you can see in this picture, there's not a whole lot of disease that's evident. Despite the motion artifact here, the patient very likely succumbed to the treatment related or non-treatment related issues. So issues here in this particular case is the discharge from the ED with the presumption that there was some infectious disease despite his cancer history. Delay again to consulting neuro-oncology, and then the rush to judgment that this patient would be better served in hospice. He lived about 2 years after the initial diagnosis, and there was noted limited education around how we overlap systemic therapy with the intrathecal therapy and the goals for doing such. The final case that I want to talk about is a young lady who was noted to have triple negative breast cancer and she had a long history of seizures. She underwent multiple diagnostic tests that were very consistent with leptomeningeal disease, not to mention the full imaging of the neuroaxis, as well as an LP that demonstrated malignant cells, which is the gold standard for identifying this disease. So we had this imaging here with the clear outline of leptomeningeal enhancement there in this particular patient. We also had the diagnosis that showed it was positive for malignant cells on the CSF. Unfortunately, her primary team was not necessarily convinced, and maybe the patient demonstrated a wonderful KPS and didn't necessarily look like what they would expect. This particular disease, people die within about 6 to 8 weeks of the diagnosis if there is no systemic therapy added or no radiation approach taken initially. So using an assay through the company Biocept, we were able to, when they decided to do one more lumbar puncture for confirmation, they consulted our team. Our team got involved and ordered a Biocept assay where we were able to detect 60,000 cells in this patient's CSF. The CSF was the color of milk when we drew the CSF off. We noted that it had two FGFR1 and a HER2 positive HER2 positive markers there on the cells. Remember, this was a once triple negative brain cancer patient. So we had a new target. We underwent whole brain radiation, our standardized Ommaya reservoir placement, and then intrathecal therapy with both methotrexate and HER2 targeted therapy. We were able, within 2 treatments, to get this down 90%, 90% reduction in those cells. And then, of course, now the HER2 is not detected. That does not mean that she's no longer HER2 positive, but we've been able to successfully target those cells to a degree where they're not able to be identified. So here's her these are cells per million. So still at around her 67,000 cells. And we were able to treat her effectively. And then at one point she had to go into rehab for her overall disease. She had become quite deconditioned, went into rehab. And during that rehab period, we were able to test her here and determine that the cell count had gone up. It was still not as high as it was initially. And the patient's clinical function, the CSF had returned to champagne colored, and really very nice response overall for this patient. She had another period where she had to take a drug holiday, and you can see this went back up. Her very latest treatment was actually just yesterday, but this therapy that you're seeing here is for February 2nd. Really being able to watch this patient improve clinically, have the data to support that, and the NGS and molecular testing done on these cells and looking at cell-free DNA. Some of the take-home issues here are related to the delay in recognizing that they had already detected leptomeningeal disease and relying on that data. I call that analysis paralysis, and really not moving forward in the benefit of this patient, understanding that this is a rare condition and thinking that maybe it was something else. There was a delay to consulting our team. Some of the barriers related to rehab and systemic tolerance, those things we expect, but being able to monitor those patients through that time point we were able to identify where the weaknesses were in her treatment and how we should modify, maybe speed up or turn down treatment, maybe even increase the dosages. Some of the resistance to starting this new and innovative technologies using these particular assays has been limited. Many institutions do not use Biocept, or maybe they use some other type of a liquid biopsy, but I wanted to present this one here. Again, this patient was excluded from clinical trials. She is still alive today, but I know that that will be one of her limitations. I want to make it clear that some of the goals for treating leptomeningeal disease, they're very clear. It's to return the patient to decisional capacity and disrupt further neurologic decline. We're trying to improve the longevity of the patient's life with quality. And so a lot of people think that it's futile to treat leptomeningeal disease when patients have systemic cancer and they're evaluated and determined to have leptomeningeal dissemination of their disease. Many times the discussion of hospice comes up. So I want to show you guys the development of a standardized approach in an Ommaya clinic, what we were able to do for breast cancer patients. This was the median overall survival for patients who underwent the typical treatment for leptomeningeal disease, if any. And here is those patients through a standardized process developed through our Mayo Clinic for melanoma patients and then for lung patients. You understand that lung patients typically, by the time lung cancer is diagnosed, it is already metastasized most often. Breast cancer patients they are afforded the best, greatest benefit. So when we talk about the epidemiology, pathophysiology, and diagnosis of leptomeningeal disease, these 4 slides will be very brief. Basically, the manifestation of this, it's only in about 5 to 10% of cancers. I argued that number that was documented back in 2011, not many studies or retrospective reviews or even prospective trials can be done on such a very rare disease with a very short lifespan. These cancers typically happen in solid tumors, breast, lung, melanoma. I think it's really important to understand that there's three main compartments that this disease takes place in: cerebral, posterior fossa, where you get a lot of cranial nerve changes, and then the spinal cord and the roots. 1/3 of the cases will present localized to a single compartment, so it's sometimes easy to miss, but it is very rarely, if ever, found incidentally. Patients will present with symptoms, and we should not miss hydrocephalus or elevated ICPs. The disease can be spread both perivascularly or through direct extension. Direct extension either from skull mets that touches down into the subarachnoid space into the brain, either from parenchymal disease, jumping hold of vascular pathways or moving into these Virchow-Robin spaces. We also get sometimes surgery can cause a direct inoculation of those cells to be disseminated into the CSF. Sometimes we look at the CSF, and too many people, all too often, do we say the cytology was negative and therefore leptomeningeal disease is not the case. So that is not true. Most of the time, cytology is insensitive to determine leptomeningeal disease. Now, if you get the cytology and it says there's present malignant cells, that's the gold standard, and the patient does have the diagnosis. But independently, the MRI, the CSF studies, or the clinical findings are not sensitive to diagnose a patient. So usually you'll have a constellation of these symptoms. Get the full neuraxis MRI. And like I said, the CSF is the gold standard for cytology if it's positive. But looking at elevated proteins, elevated white cells, and elevated opening pressure, and most important is the glucose is low, less than 65% of the serum glucose done around the same time. This would be positive for something eating up the glucose in the CSF. So I always make sure that people understand that when the reports are read, it'll show you that the glucose is normal, and it may be 65, and that's about normal. But if the patient has a serum glucose of 200, then that is not normal, and something is indeed going on in the CSF. So this is a disease that is increasing as a late-stage complication of cancer, and it's mostly due to the fact that patients are living longer on better systemic therapies. The brain becomes a sanctuary site for these cells to go because our cancer therapies don't cross the blood-brain barrier well. And because these four compartments in the body, the eyes, the testes, the brain, and the gravid uterus are all places where the immune system really has a paucity of any activity there. And so the brain becomes a great haven, especially with its barriers. But we're also better at detecting these diseases using more accurate diagnostic tools and really being able to identify this more accurately. I would imagine that the numbers are really much more striking than the latest reports. So I think that we need to work to identify more CNS penetrating agents that work at the initiation of our systemic therapy and our cancer diagnosis. Improve our communication with our subspecialties, reaching out to neuro-oncology and some of the other subspecialties as we're dealing with patients with systemic cancer. And then standardizing our approach to treating leptomeningeal carcinomatosis. We also, with a series that our team is ready to publish now with 182 patients on this, we want to show that people that are diagnosed with leptomeningeal disease, if they're placed in these standardized Ommaya clinics for the standardized care, these patients would be ideal to go on to clinical trials. I want to take one moment and demonstrate a media file that gives you guys a good idea of how this patient's imaging went from all of these areas of leptomeningeal enhancement to 2 months later in treatment. This is our picture there. I couldn't seem to get the media to work inside the top, but thank you very much.
Thank you very, very much. That was a great talk, Dr. Gatson. I think the take-home message that I'm getting is that we need to have better communication with general oncologists because often we, or the neuro-oncologists are not called in time, or they're not thinking that leptomeningeal disease is a treatable disease. And I think that we need to educate our colleagues who have patients when they get brain mets, especially in breast cancer, and don't jump on it and get in touch with us. And your results are very encouraging, and thank you so much for your wonderful presentation.
Thank you.
I think we're going to move straight forward to